Welcome everyone to our 2022 Global Health Leaders Conference at Johns Hopkins. It is Tuesday, July 26th. My name is Siam Rezwan, the conference chair, and today we are delighted to be having Dr. Deborah Birx, who will be interviewed by Dr. Joshua Sharfstein. I could spend the next hour introducing Dr. Birx and Dr. Sharfstein, as they both have done so much incredible work. But to briefly introduce them, Dr. Deborah Birx is a world-renowned medical leader who has focused her work on clinical and basic immunology, infectious disease, pandemic preparedness, vaccine research, global health, and more. She has served as the U.S. Global AIDS Coordinator, where she oversaw the U.S. President's Emergency Plan for AIDS Relief, and as a U.S. Special Representative for Global Health Diplomacy. Dr. Birx has also served as director of the CDC's Division of Global HIV/AIDS, and more recently as the White House Coronavirus Response Coordinator, where she used data integration to drive decision-making and worked closely with state officials across the country to provide state-specific advice and guidance. She has recently authored a book, Silent Invasion: The Untold Story of the Trump Administration, COVID-19, and Preventing the Next Pandemic Before It's Too Late, which will be a focus of our session today. Dr. Joshua Sharfstein is a Vice Dean for Public Health Practice and Community Engagement and Professor of the Practice in Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. He is also Director of the Bloomberg American Health Initiative and has served as the Secretary of the Maryland Department of Health and Mental Hygiene and as Principal Deputy Commissioner of the U.S. Food and Drug Administration. Additionally, he has authored some great books on the opioid epidemic and managing public health crises, and is a host of the award-winning and excellent Public Health on Call podcast. So Dr. Sharfstein and Dr. Birx, it is an honor to have you both here today. I'll go ahead and turn things over to you, Dr. Birx.
Great to see all of you and your different backgrounds. I'm going to just share some concepts early on to kind of get you thinking about public health and data and communities. And I love Dr. Sharfstein's focus on communities. So I'm just going to share with you a couple of slides so that you can see where I'm coming from, and then develop some questions around that piece. So we have tools now for COVID, and we have tools for monkeypox, but sometimes we don't use our tools effectively because we're really not working with communities in a real way that can really have an impact. I'm not going to go through all of this, but I just wanted to let you know that, to be completely clear, and so you can communicate effectively with your parents and grandparents, because I think you can save a lot of lives. We know that how this virus moves in a predictable pattern. We knew that variants were predictable because it's an RNA virus. We knew that herd immunity would not be able to be obtained with current vaccines. And we knew that current vaccines protection would wane as variants became more prominent. We also know exactly who's at risk, which still remains probably people over 65 and people with comorbidities. And we have all the tools that we need to layer protection during a surge, to actually protect people at the individual level, at the workplace level, and at the school level. I wanted to show you this slide because sometimes people will say, oh, this surge is going to be better. We're not going to see as many fatalities. We're not going to see as many hospitalizations. I'm calling your attention to that top line. That is new hospital admissions of people over 70. And we have almost achieved the same rate of admission as we did last summer. So do not be convinced that this is a lot better because hospital admissions are continuing to rise. I just wanted to take you back to how some people would like to find simple answers to problems we have in the United States, and yet some of them are actually quite complex. You may have seen the media or others talking about the higher rate of fatalities in red counties. Well, that's slang for rural America. And rural America is older, poorer, has less access to primary care, has much less access to subspecialty care, has almost no access to highly technical care, and the death rates have been higher in rural areas for decades. And just to give you some of the data, and that's why my plea to each and every one of you is when you hear someone make a simple explanation, please go back and look at the data yourself and see if the data is consistent with that explanation. So let's just say the simple explanation was rural areas are dying at a higher rate because they voted for President Trump. Let's look at this graphic. This is from nearly a decade ago. Rural America is significantly older, and urban areas are enriched for young people who are less susceptible to severe disease. This is poverty. This is childhood poverty. Those dark counties are rural counties where the childhood poverty rates are more than 50%. But also clearly on this graphic are our tribal nations that also live in poverty and also have very little access to sophisticated healthcare. Let's look at the next question. This looks like the rate of fatalities from COVID, but this is obesity from 2008. Again, highly concentrated in rural, poor areas, particularly across the South. And finally, this is access to any kind of level 1 or level 2 trauma. And what is that an indication of? That's an indication of the level of sophisticated healthcare that's available to that population. And I hope you can see, if you don't live in an urban area, you may have very poor access, either by ambulance or helicopter within 60 minutes. And so if you have severe COVID, you may not be able to get to one of these tertiary centers. And finally, this is a map from 8 years ago, showing the counties that have had premature fatalities across all age groups. And highlighted in this map of the United States long before COVID is the reality that people in that tribal nations and people across our rural counties have been dying at a higher rate for decades, yet our public health institutions have done nothing to combat this in real time. And I'll stop there because I wanted to really get you motivated to look beyond the headlines, to really figure out what is going on in the United States and what needs to be corrected. And people will say to me all the time, well, that's too complicated. That's too hard. Well, I can tell you, when I started to work in Africa and Asia in 2003 to combat HIV, TB, and malaria, everybody told me that we couldn't control HIV in Africa. And through data and working with communities, we not only ensured people could survive, but we ensured they could thrive. And we decreased the incidence of new infections by more than 85% without a vaccine. Working with communities at the community level so ensuring that they were empowered with the information and tools that they needed. Slogans are not programs, and programs have to be driven on the ground with real people doing the hard work of working with communities side by side with the individuals in that community to address all of the issues that they had. And finally, I'll leave you with the one final concept. I launched a program called DREAMS, Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe Young Women in Africa over 6 years ago, focused on the real issue of young women being more susceptible to HIV. But we couldn't approach it as you're more susceptible to HIV. We had to find out what was really making these young women more susceptible. It was lack of access to high school, lack of access and being retained in high school, being retained in college, a bridge to employment, where they couldn't see a future outside of their areas and their vision for what people had told them they were capable of versus what they were capable of. And these young women, through their leadership themselves, changed the course of incidence of new infection in those areas across sub-Saharan Africa by more than 80%. This is what's possible when you empower individuals in the community to actually lead, and you give them the funding and the voices that they need to really work alongside other young women and really become that voice for the next generation. So you are the voice for the next generation that will have to confront a lot of these issues that I just raised. But I'm hoping that our federal institutions and our administrations also begin to confront these really clear issues that have been demonstrated now by COVID, and then our poor response to monkeypox. Our response to monkeypox looked just like our response to COVID. For more than 12 weeks, we pretended it wasn't going to be here, despite the fact that we knew it was coming. And we didn't prepare, and we didn't make testing available into the community. We didn't increase knowledge in the community. We didn't make vaccines available. We under-tested, and we allowed monkeypox to spread across the country. That's what we did with COVID. And now 2.5 years later, we're letting it do it. We're letting the same thing happen with monkeypox, having learned nothing and not changed one bit of our execution. And so we all should be very concerned about where we are going as a country and whether we really understand implementation science and what it takes to work on the ground to have a different outcome than we're currently having either with COVID or with monkeypox. So I'll stop there. Hopefully that has gotten you excited about questions and what things could be like in the future.
Well, great. Thank you so much, Dr. Birx, and thanks for giving that great introduction to a whole bunch of different topics. I've got your book here, which is called Silent Invasion, The Untold Story of the Trump Administration, COVID-19 and Preventing the Next Pandemic Before It's Too Late. And I really appreciate, and I'm sure the students do, your coming and talking about these different topics. You talked a little bit about your work in Africa, and I just wanted to start, maybe if you could just explain to them what your job was, and the work that you did before COVID, just maybe briefly, just to give them a sense of your incredible career.
So I worked on HIV before we had anything, except for people dying. We didn't know what it was. We didn't have a test. We didn't have effective drugs. And so the minute that we had effective drugs, it became my mission to ensure that everyone around the world had that access. And through the Global Fund and what we call PEPFAR, the United States invested in people around the globe so that they could confront their HIV, TB, and malaria pandemics. And over the last 20 years of work overseas, we've actually changed the course of the HIV pandemic without a vaccine. So it's possible, even with less tools, to change the course of pandemics when you work with communities. And I know it's hard, and I know it's a lot of work, but the communities taught me what it means to listen and to adjust your program based on their feedback and the data.
And that program which you led has saved many, many lives. I'm sure they have calculated some estimate of that, but could you just give a scale to, I mean, when I'm certainly remember when there was no treatments for HIV and the concern, and so many people died in developing countries, what is the estimate? And at that time, I'll just say for context, there were people and companies, were not making the medications available at a low price, and people were basically expecting there to be fundamentally different standards of care. And it was actually President George W. Bush who said that the drugs that are available in the United States should be available around the world, and created this program which you led. Just some order of magnitude, how many people do you think that program saved?
Well, I love the way you phrase it, because it was unacceptable to me to find people dying from a lower standard of care. And I can tell you, so it's well over 25 million lives saved, which is remarkable with flat funding since 2009. So a lot of people will say, well, you need money, you need more money to do this, or you need more people. No, it's how you use that money and how you work with people that is a program that's successful. So we've had flat funding since 2009. In 2009, we had 2 million people on treatment. The program right now has 19 million people on treatment and huge prevention programs with flat funding. So when CDC or some other agency says, well, it's because we didn't have enough money, it's never that. It's the choices that they made with that money. And if you use data and we listen to communities and you use that to make the right choices to implement the program that that community needs, then you'll have successful programming. And it was a shock to me to come back to the United States in March of 2020 and find less data than what I had created in sub-Saharan Africa to run the PEPFAR program that was started by President Bush, and to find less resources and healthcare than what I had created in Africa with just $4 billion a year.
Great. Well, we'll get a chance to talk about, I think, some of those issues in public health in the United States. But you get the call, help, you said no a couple times, and then, they prevailed upon you to help with COVID. How would you describe the role that you had? And I say this having read your book, and I'm not sure I could totally describe it. What role you had, not because of you, but because of the situation you walked into and a little bit of the chaos that was going on in the White House at the time. So looking back, what was essentially the role that you played during this period for the Trump administration?
So I had the advantage of working with heads of state for more than 20 years around the globe. So I had learned that you don't always get what you want in the head of state, and you work with the team you are given. And so I came into the White House knowing a lot of the difficulties that I would confront, because I've confronted difficulties like that around the globe for decades. My role was to figure out how to find a solution or make one. And so that's what I did, all by utilizing data in real time to identify where the gaps are and work to either find a solution and get that executed or make one.
So you don't always get to pick the head of state. That is definitely true. And in this case, we were working for a head of state who initially was quite receptive to some of the ideas that you had, and over the course of the first year became less and less receptive, as you describe. Wouldn't wear a mask for a very long time, despite the evidence on that. Was very aggressively pushing a medication that turned out not to work and probably caused some harm, and hydroxychloroquine for people. He eventually, really declared war on governors who were putting in place restrictions that you thought were reasonable. And so it was a pretty challenging environment, led by some of the decisions and the statements that the president was making. That whole time, you were trying in all kinds of ways to make the best of it. And people were wondering why you didn't kind of call time out and say, hold on a second, what the president's doing is actually harmful here. And I think it's a dilemma that people, face from time to time. How did you work through that dilemma? It's very clear what you thought. You thought that he was wrong on all these things. And, you mentioned the rural areas. I'll just say the rural areas, and particularly the more conservative voters, are much less likely to get vaccinated, even though they're older. So, that puts them in harm's way. So what he was doing really did matter for people who supported him politically. A lot of them died. What's going through your mind as you're thinking, I want to make the best of it? On the other hand, that situation you're dealing with is essentially getting worse with each passing month.
So you have to constantly adjust. And that's a lesson both for life and in programming. So I think sometimes people get so wedded to what their perceptions and assumptions were that they're going to make that work even if it is clear evidence that it is not working. Sometimes as parents we do that, but I can tell you very clearly that people would just honestly were looking at a very different pandemic and wanted to make COVID into that pandemic and then weren't willing to adjust. And I think as long as I could see that I was making progress on the implementation. So let's be very clear. The communication at the presidential level was not the communication that you need in a pandemic. Because when you don't have tools, all you have is behavioral change. And to have behavioral change, you have to have clear, consistent communication about why it's important and show clear evidence base that it's effective. And I think, so let's put that aside and be very clear. Communication was extraordinarily off the rails at the presidential level about what was needed with COVID. But you can't let that stop you finding the Republican governors and the governors across the United States that were responsible for putting in the mitigation that was needed, working with each of them to ensure that the statewide and citywide mitigation was occurring based on the data. And I think there's a lot of things we did to make that happen. We went to 44 states. We were on the road for 7 months, but we also wrote a weekly report to every single governor that summarized in 11 pages of graphs what was happening in their state, county by county, what direction the epidemic was going, and what steps they needed to take as recommendations to change the course of the pandemic in their state. And that was for every state and territory that we worked with.
Thank you. Just one more question along these lines. I want to ask you more about the state, but was there a line in your mind that would have been like the breaking point for you staying there? I know at some point in the book you described those very important reports, they were getting censored essentially. People in the White House were changing what you wanted to say. You were trying to hide things in the report. You couldn't use the language that you wanted. A lot of people were wondering, knowing and respecting you, at what point, can she continue to be, have her point of view treated this way and still stay? How do you think about that? I want to just read one part where you said, you don't abandon the battlefield in the midst of a fight because it's hard or because it could damage you personally. You stay, you redouble your efforts. And that's what you did. I mean, going to states, doing those things, but at the same time, even that started getting watered down over time. Like, how did you put that together? This is something that, I've been an appointed official at the city, state, and federal level. And in my mind, I did have some lines. A couple times I would say, like, I can't do that. Was that in your mind anywhere? How did you think about that question?
I think if they had ever prevented my traveling and communication with the governors, that would have been my line. And if they had ever said, you can't do X, which shockingly, and I'm still shocked to this day, if you get your hands on those governors' reports, they are saying exactly the opposite of what the president is saying. And I went to the vice president because I'm not naturally a rogue human being. So I wanted to make it very clear. And after Scott Atlas came, I made it very clear to the vice president. And I said, I'm saying exactly the opposite of what the president is saying. And Scott Atlas is saying to every governor, to every mayor, and to every American citizen on media. Now, I couldn't do national media, but I did 200 or 300 local media stations continuously so that I could get the voice out there. But and the vice president said, you do what you need to do. And so to me, if the president had ever come back and said, Debbie, you can't do this, you can't do that, he gave me only one policy And that was in April, sometime that first week of April, where no policy piece that the president ever gave me related to COVID, beyond the proactive policies of decreasing travel to Europe and the 15 days and the 30 days to slow the spread. And so if he had ever given me a policy piece that I felt I couldn't follow, then I would have left.
Fair enough. I totally appreciate that answer. And just for the students' reference, you referred to Dr. Scott Atlas, who was brought by the president to inform him on COVID, despite his views that are far outside the mainstream, including there was no point to wearing masks and really essentially embracing the idea that maybe just everyone should go ahead and get COVID. This was before vaccines were even available. So that was just it's really a kind of dramatic part of the book as somebody who, you hope to have a constructive dialogue with, really turns out to, essentially do everything he can to push you aside and kind of monopolize the president's attention. I want to ask a couple questions, and then I will go to the student questions. So please feel free to start throwing questions in the chat, and I'll call on students to unmute if you can, or I'll read the question as we get into it. I want to talk about the state of public health. You started by saying, it was kind of shocking to you when you got back that you had different different experiences in Africa. The state of public health in this country has been pretty seriously impaired for quite a while. There have been many reports documenting the challenges, and a lot of the challenges have to do with just the core work of public health. That map that you showed of the chronic disease, particularly in the South, there are health departments in those areas that are trying to do things. Some of them are very underfunded, and maybe you and I would disagree with this. I do think that there's a significant funding gap affecting local public health, particularly in this country, which makes it almost impossible for them to do much of anything, particularly when they have almost no money. In many cases, they're shutting down. But the question I want to ask is, do you think that the challenges that public health in America has are being, how would you characterize those? Going around, seeing what's available, the data infrastructure, the workforce, the laboratory systems, what did you learn from that, and how can you put that in context given the other things you've done in your career?
So that's a really great question. So I think number one, you can't let money stop you, because there will never be enough money in anything. So you have to figure out a different way to work. So what would I have done? Well, fundamentally, there's not enough human capacity in the States as you describe, but there's thousands and $10 billion in Atlanta. So I think Atlanta belongs in the States, working alongside state and local officials, bringing their expertise, decreasing the size of the footprint in Atlanta and increasing the size in every single state, and then setting up public-private partnerships. I will tell you, there isn't a private sector person who said no to me. The CDC said no to me. When I asked them to get data from every single hospital, they said no to me for 3 months. I called the 6,000 hospitals and said, I need your data on a daily basis because it will save lives, and I can get you then the things that you need to ensure that you save lives. Within a week, I had 93% of the hospitals reporting, and within 2 weeks, 96%. So we limit ourselves. We decide something can't be done, but then we don't ask and we don't work every day to make it happen. And I think that is part of our tragedy of public health in this country, that we're too centralized. We need to decentralize into the states and local communities. We need to do behavioral science and implementation science. Do you know that we spent the last 20 years mapping vaccine hesitancy to flu? 20 years. I can tell you exactly where flu vaccine rates are low by age and ethnicity. And you know, we did nothing. We did nothing with that data to act on that data. And we didn't change one thing over 20 years of vaccine hesitancy. So this is what I'm talking about. I would
Right.
stop recording data for publication and record data for action, and work with partnerships with Walmarts and local companies to change the course of health in those counties. They want a healthy workforce, and we want a healthy workforce. So broaden your horizons, work with people that aren't traditionally in your box, and make things happen in a data-driven way.
How do you, thank you for that answer. And I think there's some great examples where that has happened in public health. It's hard to sustain that type of engagement when there's not this kind of national emergency. But one of the challenges that in the United States, where we do have a pretty diffuse public health system, is that the local leadership sometimes isn't all that supportive of public health interventions. You could go back to tobacco, where there was a huge, if you looked at the map where tobacco regulations or basic tobacco precautions were put into effect. And you saw that with COVID too. You saw a number of governors pretty lukewarm even on vaccination. So is there a risk if you say, let's just push it out to the community level, that you wind up with a pretty stark divide in the map of who's living and who's dying based on where they are from?
No, because you have to hold everyone accountable by using the federal dollars to drive accountability. We put out billions of public health dollars. I mean, I just want to be clear. No one has got the CDC budget. They have, I think, $10 billion. So this is not a money issue. This is an execution issue. Yes, we would all love more money. You also have to find out what's driving those county commissioners for their decision making when it comes to public health. And I found with DREAMS, which was a big prevention program we launched for young women in partnership with young women, we went to young women in Africa, which had a 10 times higher incident rate of HIV than their age-matched male cohort. And we said, what are you interested in? I mean, what are your concerns? And they listed their concerns for me. So HIV was like number 10. So I knew that in order to develop that partnership with the young women, I was going to have to address the other 9 as well as the 10, finding ways for them to have school fees so they could stay in high school, finding bridge to employment so that they could have an effective income. I had to do all those things. And so I find that sometimes we want to impose what we're interested in on others, and then we just keep beating them with the same words, maybe a little bit louder to try to get their attention, rather when starting with the premise of what concerns you in the community. What are you really seeing as your issues? And you start with that where there's consensus, and then you can get to the hard pieces, because then the people respect and trust you as an equal partner because you've listened. And public health has not spent enough time listening in this country to really ensure that they can implement effectively.
Great. Well, why don't we start mixing in some of the student questions? Arnie, I see you have your hand up. I don't know if you can unmute. And maybe if you could just introduce yourself, say where you're from.
Oh, hello. My name's Arnie, and I'm from Florida. Right now I'm in India, so I'm sorry, it's a little noisy. But thank you so much for coming to speak today. And my question is, I remember when I first saw you was when it was the White House press briefing conference, and Trump looked over at you and asked you if ingesting, I think it was disinfectant, was okay, and you had to be quiet and not say anything back. And I guess my overall question is, how do you handle when a overarching party is taking away your validity? Because the same thing happened with Dr. Fauci as well. And how do you handle that and overcome that?
So first, and this is the unfortunate thing in our country right now. President Trump's back was turned to me, and he was talking to the DHS scientist in that press briefing. And I had asked the DHS scientist to study the effect of sunlight versus disinfectant so that children, this was April, so that children could get back out to their playgrounds. And so the DHS scientist presented all the data in task force, and then someone took them to the Oval Office. And the DHS scientist was in the dialogue with the president about sunlight and bleach. Now, he was a basic scientist, but he was encouraging the president in the thought process that this could be a therapeutic. And in the end, the president turned back around to me and said, could this be a treatment? And I said, not a treatment. Now, obviously, I've rerun that 1,000 times because it was that only happened once, but things like that only happen once for me, and I make sure they never happen again. And so that's the one thing I can say to you. Just make sure that you've learned from that and it never happens again. I think that a more proactive way I could have dealt with that is I could have gotten between the DHS scientists and the president. So I could have gotten up from my seat. I certainly couldn't have gone to the microphone and tackled the president. That is not something I would have done. But I could have gotten between the DHS scientists and the president and very early on said, this was for playground equipment. This is not a treatment for human beings. And I could probably stop that. But I have to say, I was trying to figure out, how did he get from playground equipment to treatment? And so when you see me looking at the floor, I'm trying to figure out what is going on, because this was about playground equipment. And so I do believe it is very important to figure out a respectful way to intervene in real time, not wait till the time when they finally turn to you and talk to you. And that was a very difficult situation. I hadn't been in a situation like that before, but I made sure it never happened again.
Thank you. Vicky, do you want to go next?
Hello, Dr. Birx. Thank you for your sharings. My name is Vicky, and I am a senior from Vancouver, Canada. My question for you today is, why were COVID-19 transmission rates were initially higher in many developed countries, such as the US or Italy, while many in Asia, especially those bordering China, experienced lower infections? Which factors could influence that, and especially the socio-economic ones? Thank you.
So that's a great question, and there's multiple components to that. The biggest one out of Asia is they understood the devastation of SARS. I lived and worked in Asia at that time. SARS in 2002, 2003 hit the scene, unknown what it was, highly deadly. About 12 to 15% of everybody who was identified to be infected died across age groups. Communities understood and masked. And so when I was working in Asia, everybody was masked. And so masking became, both for pollution and for infectious disease, mainstream. And whole communities and populations would mask upon an alert that there was a new infectious disease. So Asia in general masked and mitigated early. Secondly, the infection rates in Africa were probably not lower, but the median age is about 15 as opposed to our median age of 35. And so they had, majority of their population was not susceptible to severe disease. And so if you're really only looking at severe disease, you would interpret it as having much less infection. They probably had equal infection, but significantly less severe disease. But the third part of your question, which is critically important, is for decades, we had planned for a pandemic that was over there and got stopped over there. So there was a lot of global health security. And no one planned for a pandemic that was worse in high income countries because of our age and our comorbidities. than low-income countries. No one planned for that. And so coming out of this, there needs to be a coalition of high-income countries that share data, because those countries did share data and they did send me all the information in March because of my work with them on Global Fund. So that allowed me to warn the American people of who was going to have severe disease, which was incredibly helpful to America. But we ought to be doing that systematically rather than it's because of who you know.
The relevant is a question that I think Agalia is going to ask about the U.S. role globally, and perhaps as you answer that, you could talk a little bit about the role of the United States in the World Health Organization. President Trump, when you were there, pulled out of the World Health Organization, really pulled back from international cooperation. But Agalia, could you go ahead?
Yeah, thank you, Doctor. I was going to ask about kind of the role that the U.S. has on the global scale during these emergencies. Like Dr. Sharfstein mentioned, the U.S. did pull back in our global cooperation during the pandemic. So in the future, how can we improve global cooperation and use our resources to help other countries?
Great question. So first, we had just made our payment to the WHO. So the good news is, although there was a lot of rhetoric, and that's what I tried to talk about in the book, there was a lot of things that were said, and then very different things were done. So we actually, I don't think in the end ever missed a payment for our assessment to the WHO, which was really critical because they needed those funds. I think secondly, let me put together your second part of the question. The US can't help others right now in a real way because we don't have the resources ourselves. And what do I mean by that? All of our essential medicines are offshore. All of our PPE that protects health workers, offshore. And when we talk about the supply chain, we have no onshore except for 3M and Honeywell and 95 masks. That's it. We don't make any essential medicines. I would say 99% of them are made in China or India. Gloves come from Malaysia or China or Thailand, some from Vietnam, and almost all of the PPE comes from China. So if we want to be able to help the world and help ourselves, we do have to have some of that capacity here. And some of that technology has to be re-onshored so that we have the ability to both ensure protection of Americans, but also others. And I think the United States has really stood steadfast in that gap of infectious diseases and pandemic response, and is the #1 funder for bilateral programs in HIV, TB, and malaria, as well as the Global Fund. We are the #1 donor to the Global Fund and all infectious disease pandemics worldwide. And I think we should be very proud of that. But then we should be proud of how we respond here in the US too, which is still lagging.
Thank you. Mitali, do you want to ask your question?
Yeah. Thank you so much for your time, Dr. Birx. My name is Mitali. I'm a rising junior at Portland, Oregon. And I just wanted to ask, throughout all your experience with this COVID pandemic, what do you believe is the most meaningful and impactful lesson that youth should learn from and be aware of?
I think the #1 thing is using data in real time to save lives. And I think, to me, that is still the #1 gap. As I said, it still exists in monkeypox. We don't use data to be proactive. We use data to hope things will be different next time. And hope is not a program or a response. And I think let's move from hope to truly data-driven decision-making. We say that all the time to foreign governments. We want you to use data-driven decision-making, but you have to get the data in order to do data-driven decision-making. And we're still not there in the United States. And so that was my biggest lesson. And the second biggest lesson is we have a situation in this country that's not sustainable with lack of access to healthcare. And that's true for our tribal nations. and for many rural Americans. And that is why we have these high rates of obesity and diabetes, and we have to change that. Insurance is not enough. They actually have to have physicians that they can go to. And we need to ensure that 20% of Americans live in rural areas. So 20% of the NIH research funds have to go to doing research on the issues affecting rural Americans. And then with that investment, we will change outcomes.
Thank you. Kirti has a question relevant to rural America.
Thank you, Dr. Birx, for your presentation. And so my question was pretty much related to this, but like, I guess it's America specifically where rural areas are really different because of like political views. So how would you reach rural areas and other areas where like views that aren't related to health necessarily affect their health decisions? And if they don't listen, then what would you do? And like, would you end up reaching like local officials or like, yeah.
Yeah, that's a really insightful question. And so, you know, obviously working overseas for 20 years, I had to work with people who didn't respect the LGBT community. In fact, they may have criminalized activities within the LGBT community. Yet I had to figure out how to have a response that was needed to ensure that everyone had access to services and prevention and treatment that they needed, including the LGBT community. And we always found a way. Sometimes not easy, but there was always a way. And I think we have to ask ourselves, is it the chicken or the egg? Did rural communities become this partisan because they've had decades of neglect and lack of a federal government that saw them and responded to their needs? And therefore they became more and more alienated and very much susceptible then to someone who said, I see you and hear you, and that dynamic. Or, you know, are there fundamental differences among Americans? And I don't know the answer to that question yet. I find that just right now, Paxlovid. If you live in an urban area, you can get Paxlovid. If you live in rural Mississippi, no matter if you're a Democrat voter or a Republican voter, because let's remember, people in rural America are not uniform. Even in the most red of red counties, it's probably 60-40, 70-30. And so it's not like everybody's thinking the same way, but I can tell you none of them have access to Paxlovid. Because there isn't a Walgreens, there isn't a CVS, there isn't a federal test and treat program. There's a dollar store. There's churches and dollar stores. There's nothing else. So, you know, we make this a self-fulfilling prophecy when we don't get on the ground and find out what rural communities need, and we don't listen. And we decide. Those of us in Atlanta or those of us in Washington, we're deciding what people need rather than us going and listening to what people need.
Just to follow up, if they want a pharmacy, what do? Let's say you have a community of 100 people. I mean,
so,
is it a failure of the federal government to pay for a pharmacy?
No. So that's like in Africa, we had a lot of places that didn't have pharmacies. So you work around. So what do? Fortunately, we have telehealth. So right now, we know where every single American lives that's over 65, no matter how rural, because they're registered within the Social Security system and within Medicare and Medicaid. We know where all those people live. Right now, instead of saying to people, go online and order tests, we could send COVID tests to every American over 65 with instructions on how to test during a surge, the hotline and telemedicine to call, and the fact that overnight, they're gonna receive, like Amazon boxes, their Paxlovid. So there's solutions for each of these pieces, but instead of working with the private sector or working with people at the community and explaining to them how to be empowered so that they have the information that they need in order to get Paxlovid. We make the assumption that they're not going to use it, or they're not going to know how to use it, or they don't have this, or they don't have that. I heard all of this in Africa. People told me that we couldn't get treatment to Africa because they didn't know how to tell time, so they couldn't take their pills. So, you know, a lot of people have perceptions. They're not necessarily correct. So when people say to you, this is true, it is often their perception. So next time they say that, say, show me the data that you talked to that person. You know, what is the real on the ground? What are the demographics of that county? What does that look like? What do people have access to?
Great. Famida, go ahead.
I'm Fahmida, I'm a senior from Dhaka, Bangladesh. And my question was, as you said, Dr. Birx, that you have worked in Asia. So what do you think in Asia is a potential strength, like in Asian countries, that can be maximized and leveraged in order to improve the health outcomes here?
So they don't pretend that there's a difference between healthcare and public health. So in those countries, public health and healthcare are one. So they don't have two separate systems. So there's only one data set. And so the public sector hospitals, the private sector hospitals, the public sector clinics, the private sector clinics work together with governments and communities to improve the health. And maybe it's a community health worker that is working home by home. So there are models of effective implementation. We're not willing to break down our silos, and we're not willing to create those public-private partnerships that would help facilitate breaking down those silos. I can tell you even now, people are saying, I just need more money in public health and I need more people in public health. Well, no, maybe you need an alliance between the communities clinics and the community hospitals and the regional hospitals to create that coalition. So there's no division between public health and clinical care. We have to use the system that we have. We may not like the system, but it's a system that we have. And I think creating and maintaining parallel systems is always going to be fraught with significant problems, because people, I bet if I asked you, where's your public health lab that you were going to go to get tested for monkeypox? You would have looked at me like I had three heads. What do you mean a public health lab? You wouldn't even know where it was. So people know where their clinics are. They don't know where their public health labs are. So let's stop making tests just for public health labs in the CDC, and let's make tests for infectious diseases available through every clinic and every hospital across this country.
Great. Well, I think we might have time for one more question. We're getting a bunch of monkeypox questions. I wanted to see whether Sarah could ask her question.
Hi, Dr. Birx. Thank you so much for your presentation. Considering we know what happened when we didn't respond to COVID and we ignored the issue initially, what do you think was the reason we didn't respond to monkeypox quickly, and how do you think we should change the way we respond in the future? Thank you.
You know, that's just a brilliant question, and that should worry all of us, because the initial monkeypox response looks remarkably like January and February of 2020 and COVID. So let's just visit that for 30 seconds. So we knew in May 7th that there was already monkeypox in the UK. And we know that every single variant of COVID that got to the UK got to the United States. So we know that there are transmission channels between the UK and the US. We also knew in the UK, it was primarily in men who have sex with men. Not sexually necessarily transmitted, but transmitted by close personal contact between men who have sex with men. Instead of immediately sending out the alert and making monkeypox tests and monkeypox vaccines available in every urban area where we knew the virus would go first, we sat and we waited and we waited. And then we created monkeypox tests only for the public health labs. And then we demanded every monkeypox test gets certified by the CDC and confirmed there. And so we completely made it impossible to test. And that's what we did with COVID. It's exactly the same script. And here we are 2.5 years later with the same failed public health response. And I am sure there are nearly 8,000 to 10,000 monkeypox people out there infected because they're not getting tested adequately. They're not getting vaccines. We have a vaccine. It's a smallpox vaccine, but it works against all these pox viruses. So we had the tools to be proactive. Instead, we wait and we wait and we wait until it's a crisis, and then we'll respond. And I think this is what's fracturing trust with our public health institutions, because they're not learning the lessons of the last pandemic to confront the new one.
I would just add one other thought to this, and just to see whether you agree, Dr. Birx, that this is always going to be a challenge beyond the initial laboratory response, that this is going to be a challenge of educating people, reaching at times very high-risk communities, helping them understand what the risks are, and getting tests and treatments and all that to them. That's an infrastructure we do not have in this country at this point. It's very weak. And so it's going to take a while to rebuild. There's got to be a decision to rebuild that. And until that happens, no matter what comes down the pike, whether it's obesity or heart disease or different types of preventable cancers or smoking or HIV, which we're still, not doing nearly as good a job in this country as we could be doing. All those things are struggles, not so much because there's somebody, in my opinion, somebody in Atlanta making the wrong decision, but because we have not built a strong public health system in this country that is able to serve the needs of communities in partnership with communities and with the businesses there, just like Dr. Birx said. We don't have that. And until we have that, we're vulnerable to many different things. I don't know, Dr. Birx, if you agree with me there.
I remember hearing these exact same things in 2003 about confronting AIDS in Africa. And I think what you have to do is take the resources that you're given and that you have, and you find an institution, an academic institution like Johns Hopkins or a state university, and you work to build that coalition, and you work to wicker funds together to do exactly what you described. And once people see that it's possible, because right now people are like, oh my gosh, this is a disaster, we can't fix it. You've got to help create that roadmap of solutions at a statewide level. I believe it's doable, and that's what I'm committing my next several decades to, is really finding a 21st century solution to, I think public health did not evolve past the 20th century, and they're still trying to make 20th century solutions work, and they aren't going to work today. And now we have to figure out how to leapfrog that. And I think there are people who want to help, and it's our job as leaders in public health to find that governor, that mayor, that Walmart, that health commissioner that's willing to look at things differently and do things differently, and really show people that you have a solution. There are solutions out there, and we can do it together.